Good afternoon. Welcome to Medical Grind Rounds, to our folks here and at Parnassus, as well as the folks online. I'm Bob Walker, Chair of the Department of Medicine. Today is a special Grand Rounds for us. This is every year we choose 4 individuals to be Master Clinicians of the Department of Medicine. These are the doctors, the people that you would recommend that family members see. And in part to commemorate that, we bring in a visiting professor who is similarly a master clinician and someone who we think can highlight the importance of clinical medicine. The master clinicians this year are Sarah Dornberg, Sarah Goglin, Andy Levitt, and Neil Trivedi, all fantastic doctors. The lecture that we have in honor of the master clinicians is the Gurpreet Dhaliwal Lecture. As soon as I say that, people start wondering, did something happen to Gurpreet? He's perfectly fine and well. We had an anonymous donor several years ago who recognized Gurpreet's specialness and decided to endow a lectureship in his name, which is very, very, very nice and very well deserved. So this is the Gurpreet Dhaliwal Lecture, and our speaker is Adam Rodman. Adam is a perfect speaker for this setting. He is a general internist and hospitalist and a medical educator at Beth Israel Deaconess Medical Center, as well as an assistant professor at Harvard. He directs AI programs for the Shapiro Center for Education Research and leads the task force there for integration of AI into the medical school curriculum. I got to know Adam well because I was leading a group for the Macy Foundation looking at AI and the future of medical education, and Adam was an absolutely key participant in that. And I see him as really one of the nation's leaders in thinking hard about the future of AI, particularly as it pertains to diagnosis and to medical education. He's an associate editor of the New England Journal of Medicine's AI offshoot. His research, and it's really groundbreaking research, focuses on med ed, clinical reasoning, the integration of AI and other diagnostic technologies. His first book was called Shortcuts Medicine. He's has also been the host of the American College of Physicians podcast called Bedside Rounds. Adam was trained in internal medicine at OHSU and then did a fellowship at BI Deaconess while also doing some clinical work in Botswana. So he's had an incredibly interesting career. I think he is already making a tremendous impact on the way we think about medicine in a world where we have these new and breathtaking technologies, and we're thrilled to have him here as the Gurpreet Dhaliwal visiting professor. So Adam, welcome.
Oh, thank you so much. Turn on my mic. Probably could just, oh, look at that. I'm even louder now. So first of all, I just want to say, when I was a medical student, Gurpreet Dhaliwal was my hero, which is really, I was a very nerdy medical student, the fact that I'm saying that. So the fact that this is the Gurpreet Dhaliwal, oh, I was about to say memorial. Sorry, that's very awkward. He's just on spring break. He's still doing well. Anyway, I'm so excited to be here. Hi, everybody. So I'm Adam. Wait, where did Suri go? Oh, hi, Suri, former resident. So there's a nice persistent BI UCSF connection. So well, first, conflict of interest. I am, or was, as of yesterday, a visiting researcher at Google. So major conflict of interest. You guys should know. I actually am going to, not because of that, use a Google model, just not because of my conflict of interest. Well, maybe it is because of my conflict of interest, but because it's really good for the purpose of a demonstration. So this lecture is called Towards a Medical Superintelligence, Human Reasoning, Language Model Reasoning, and the Race Towards a Strange New Type of Collaboration. So I'm going to start. We're here to talk about how we make decisions. So I'm going to ask a very simple question. Maybe I'll even ask the audience. I'll ask the audience, what does clinical reasoning mean to you? This is nice that it's a small room.
A list of facts from a variety of sources and matching them against patterns of diseases to try to come up with an output that helps the patient.
Okay, fantastic. So a pattern matching, a pragmatic pattern matching task. Anybody else? Yes.
Sorting through probabilities and then reassessing those probabilities as new information.
Yeah, so it's kind of probabilistic reasoning. That's sort of Bayesian view, right? You adjust your priors as you get new information. Anybody else? Yes.
Integrating knowledge, research into making a decision, along with your own experience and interpretation.
So reflecting the various sources of information, including basic science research and your own sort of empiric existence and personal lived experiences. Great. Anybody else have another definition? Hi, Christy. Well, the reason that I wanted to stress that is because whenever I say a recent study, it just makes me seem very old because this study was published about 15 years ago and I'm just getting old. But there was a study looking at reasoning experts' definitions of what is reasoning. And it should not surprise anybody here that we have, I don't know that they're conflicting, but multiple different definitions of reasoning that even experts can't fundamentally agree what the nature of reasoning is. So what I'm going to first do is to talk about our kind of basic psychological understandings of what the reasoning process is before getting to the technology. So at its most basic, it's actually pretty much what Dr. Wachter said, that is, diagnosis, which is the classic reasoning task, is a classification task. So nosology is a classification system of diseases. Fundamentally, and this goes back thousands of years, what we're doing when we think about, well, if we were an ancient Greek physician and we're thinking about someone's imbalanced tumors, or if it is a morning report at UCSF in 2025 and we're thinking about febendazole, drug-induced liver injury, we're trying to sort information to fit certain patterns for either a diagnosis or a list of diagnoses. Now, that was, I would say, the dominant explanation until the 1970s. So in the 1970s, like this is the era of cognitive psychology, when cognitive psychology comes of age. So you think Thinking Fast and Slow, Danny Kahneman, Amos Tversky, RIP. This really came into medicine by the work of Elstein. So Elstein was working actually at Harvard in the late 1970s, and he noticed a curious phenomenon. So Elstein is famous for the hypothetico-deductive model of reasoning, which is what a lot of you just described now. That's where you make a hypothesis, you collect information to test or reject it. So he did a series of experiments on medical students and attendings, where he sat them down and he asked them to solve cases. And the students and attendings did the exact same thing. They made hypotheses. They asked questions to collect more information to refine those hypotheses. But what Elstein noticed is that the attending physicians asked very few questions compared to the medical students who asked many, many questions. And then at the end of the day, the attendings were far more accurate. So Elstein had this first insight, this is back in 1979, that there's something else going on than just classification. And now we understand this as dual process theory, which we talk a lot about in medical education. The basic overview, if you haven't read Thinking Fast and Slow, I own a copy at home and I reread it after Danny Kahneman passed last year. It is, I don't want to besmirch his memory. It's a very difficult book to read. It's incredibly boring and it's like 800 pages long. I mean, brilliant man. Perhaps Noise was his last book before he passed. That's also a very interesting book, but very difficult to read. But the gist is that Kahneman and Tversky described two interacting thought processes. One, in terms of medicine, which is very, very quick. It uses heuristics. So it uses very kind of automatic decision processes that are honed by experience, that are prone potentially to biases, but happens largely unconscious. And then a system 2 process that is, it takes work. It is very deliberative. It uses a lot of the classical thinking strategies that we think and is much, much slower. And at this point, if you were to say, is there a grand unified theory in the reasoning space that would look something like this? Don't worry, I'm not going to go over this, but this is from Pat Cross-Scary. The basic idea being that reasoning, clinical reasoning, is prone to the psychological processes that affects everything else. And in medicine, we often talk about script theory. So we did this in Morning Report. So all of this should sound very, very familiar to you. So script theory is fundamentally a theory of knowledge organization. And the idea is that this is what I heard from you guys. We get knowledge from all different sources. We get it from our personal experience. We get it from basic science, what we learn in medical school, from reading journals. And we store all of that information in our brains. And we're not like the Dewey Decimal System. I don't go to heart failure and I'm not at like E.725.5 hepatic congestion. That's not how it works. All humans, actually, in many different things that we do, because a lot of these ideas are adapted from other psychological theories, we store information in these kind of automated exemplars that we call scripts. And that scripts do not exist in isolation. They exist in networks called schema. And I mean, this is the home of Gurpreet Dhaliwal, so I'm sure that I am just repeating what he talks about all the time. The whole idea being that when we instantiate knowledge, when we collect knowledge from patients, we're almost automatically comparing and contrasting different scripts. So what does this look like in practice? You have a patient in clinic, and everyone has had this experience, right? This happened in morning report this morning. You hear a story from a patient, and without thinking, it is an automatic process, your mind starts to sort what could be going on. And what is happening psychologically is that you are instantiating a problem representation. In this case, a patient says, I can't breathe. It started yesterday. This is acute dyspnea, and you're activating a schema in your mind, which is how, I mean, there's nuance here. Gurpreet wrote a paper about this, but a schema is different than a framework. A schema is really our internal model of our understanding of the various features that go into acute dyspnea. And almost, again, everyone has had this experience, almost without thinking, you will take that problem representation and start to instantiate other ideas. You ask additional questions. In this case, hypothesis testing, a COPD exacerbation or asthma or pneumonia. And this is kind of an automatic process. This is these slides actually I took from my friend Raja Abdulnoor at the New England Journal of Medicine. And this process continues on and on until either we are satisfied with the amount of information that we collect, or we see some reason to cross over into another form of reasoning. Now, if you were to go back 15 years ago, 20 years ago, actually, when I was in residency, this was the dominant form or dominant understanding of how physicians made decisions or clinicians made decisions, which is dual process theory, script theory. I went to OHSU, so Judith Bowen at the time was at OHSU. Judith Bowen's 2001 paper is really, really influential in how we teach clinical reasoning. Probably, I mean, a lot of the work was done 15 years before by Bourdage, but she's the reason that we talk about script theory so much. Psychological, and it's not that we've moved on from script theory, but we have discovered other cognitive psychological facets that affect us. So to give an example, I have had, let's see, I woke up at 4 a.m. because I'm jet lagged, and I've had about a gallon of coffee right now. I don't know if you guys can tell that. I kind of pace anyway, so you wouldn't be able to tell the difference. But right now, if I saw a patient, well, I might be a little flighty and they might say this guy's a little bit strange, but my mind is working pretty well. At 2 a.m., when I'm admitting in the hospital, an Epic chat keeps going off and the little, it turns purple all the time and it drives me crazy. And I've got 3 different patients and my pager is going off and I'm sleep deprived and I have to wake up early the next morning. My mind is not working particularly well. And the idea, and again, none of these are particularly controversial, but psychologists have really studied over the last 15 years, all the other factors in our working environment that affect our cognitive decisions. None of this should be surprising to anybody who works in medicine in the year 2025, but this is the idea of ecological psychology, that reasoning is not just happening in our mind, but it's influenced by all of our interactions with our environment. Whoops. The other dominant psychological theory that has emerged and become very popular in the last 5 or 6 years is this idea of what's called context specificity. To give an example, imagine that you have a hospitalized inpatient. They have a pneumonia, you get a chest x-ray, it shows a nice big lung nodule, a suspicious lung nodule. Well, what is the right decision on how you should follow that up, what the next tests should be? And I think all of us immediately start to think, oh, there's lots of different factors that we want to take in. They involve, well, the patient's medical comorbidities, the patient's values and preferences, the patient's understanding of their disease, also the health system context. Is it possible to get an IR biopsy follow-up? Is it possible to get a PET scan? And all of these features are called context specificity. So the idea that reasoning can be very, very hard to measure because there are so many individual contexts for every single decision that we make. And then finally, and to me, especially in my research, this is one of the, to me, most influential ideas. And that is, we had a morning report this morning, and we went with the conceit that we started with the patient's chief complaint. I see patients in both clinic and in the hospital, and I will tell you, it is very, very rare, or I should say 0% of the time, that I'm actually walking in not having read about the patient in the chart. And what does it mean if I'm reading about the patient in the chart? It means I'm actually reading somebody else's thoughts. Now, I haven't inherently talked to that person. We're not working together, but we're communicating with other people. We're basing our thoughts on other people's thoughts, mediated through the electronic health record in different times and spaces. And again, not controversial. We spend a lot of our time in front of the computer, and these sorts of impacts on our cognition are really, really important. And a lot of the classic ways that we teach, reasoning in our own minds, or us and the patient, aren't really reflective of reality. So I don't think I need to convince you why it's important, why clinical reasoning is important, but how do we make people better, right? That has been, if I were to say, one of the overarching goals of my career is first, selfishly, how do I make myself better at reasoning, but how do we teach reasoning? And 3 large categories to go over. One, I can do a show of hands. Who is taught about cognitive biases in medical school or residency? I guess everybody, right? You teach about anchoring bias, you teach about recency bias. I don't want to depress everybody too much, but the data for teaching people about cognitive biases to improve reasoning is there's plenty of data. It doesn't work. Why? Well, I'll give an example. I remember it wasn't too long ago that, 5-6 years ago, I made a brilliant diagnosis. I made a diagnosis of Mycobacterium M. bovis bacteremia in a patient who had gotten BCG for urothelial cancer. And everyone was like, wow, Adam, that's a really good diagnosis. Do you know why I made it? I read New England Journal of Medicine, and 2 months before that, there was a CPC about M. bovis, well, maybe not M. bovis, but some type of mycobacterial bacteremia because of BCG treatment. What happened there? It was recency bias. The point being, heuristics are just how our brain works. We have heuristics for a reason, and I think that if we're honest with ourselves, we use heuristics all the time to take really good care of our patients, and we only call them cognitive biases when something goes wrong. And then more importantly, we've studied this. Education about cognitive biases makes you more aware of your biases, but doesn't lower errors. Number 2 strategy, can we de-bias people? Can we teach people ways to reflect on their care and make better decisions? Well, on this one, the experimental data is much more optimistic. So right now, if you spent 5 hours a week following up on patients that you saw, calling them, seeing how they did, using that to refine your thinking, using that to calibrate your diagnostic skills, you will become a better doctor. You'll become a better diagnostician. Who here has 5 hours a week to do that? Yeah, and that's the problem, right? De-biasing strategies work great in the lab. And I keep talking about Gurpreet as if he's here. One of the things that Gurpreet impressed upon me when I was very young was to keep a list of patients to follow up. I will be the first to admit I still keep that list. I am definitely not as good as I've become busier at making sure that I have time to follow them up, to call them to see how they're doing. It is one of these things that works, but we don't have a health system built for that, which brings us to the 3rd category, artificial intelligence. Now, there is a tendency to think of AI as something very modern, something very, we're in the Bay, so very like 2025 Bay Area. But we have actually been talking about artificial intelligence for a long time. This is a quote from Bernard Shaw, 1918, who's reflecting on how people in stores used to do all their ledgers by hand, and now they have counting machines. He says, in the clinics and hospitals of the near future, we may quite reasonably expect that the doctors will delegate all the preliminary work of diagnosis to machine operators, as they now leave the taking of a temperature to a nurse, and with much more confidence in the accuracy of the report than the guesses of a member of the Royal College of Physicians. And then he points out the observation of symptoms is extremely fallible, depending not only on the personal condition of the doctor, and this who has possibly been dragged to the case by his night bell after an exhausting day, just to make it clear we've never been free of pagers, but upon the replies of the patient to questions which are not always properly understood, and for lack of the necessary verbal skill could not be properly answered if they were. From such sources of error, machinery is free. Now, he says machine operators here. When this was published in 1933 in a book, it was an essay originally, he changed the word machine operators to a new Czech word from a play that had just been published, and it said robot doctors. So these are old ideas, and in fact, artificial intelligence in medicine is old, and it's been used. And one of the very funny things about AI is that we use AI all the time. Technologies in the 40s, 50s, and 60s would have been called AI. And once they work really well, we stop calling it AI. So to give an example, one of the most dramatic studies is in the early 1970s by Tim de Dombasle, the University of Leeds, doing what we would just say is a very simple risk calculator. But so back, prior to widespread use of CTs, you had an acute abdomen, you got an exploratory laparotomy. And Tim de Dombasle created a very simple prediction algorithm that could risk stratify whether you did an X-lap or not. It worked incredibly well in a multi-center RCT. It reduced mortality by 22%. It became used by the US Navy on board nuclear submarines in case a seaman had a acute abdomen, because otherwise they would have to evacuate the seamen and take the ICBMs out of commission, which I imagine was not very good during the Cold War. So AI technologies historically have been incredibly powerful and exciting. You go back to the early 1980s, late 70s, early 80s, there was Internist 1. So this is from, did anyone know Jack Myers? Actually, a show of hands. This may be on the East Coast, many people have met Jack Myers, chair of medicine at Pitt. I believe he was president of the AMA. Nickname was Black Jack. He had an eidetic, what's it called? Photographic memory. Brilliant guy. He is largely the reason we no longer have oral boards in medicine, because if you got assigned to him to be your board examiner, you would most likely fail. That is where his nickname Black Jack came from. But yet when he was actually just a little bit older than me, which shows that I have a lot of things to accomplish, he was like, I'm chair of medicine. I've accomplished so much. So he spent the next 10 years trying to model out with a computer scientist his thought processes. And Internist 1 in the year 1982 could solve many New England Journal CPCs. It was a remarkably effective program. And there was so much optimism that we were soon going to have general purpose diagnostic AI. Now, we can go into all the reasons for this. I'm not going to now, but there was basically a deep freeze in diagnostic capabilities. And from roughly, there's a famous paper in 1992 and then 2012, so 20 years apart, Mark Graber was the author on the second paper, that basically showed a freezing of the diagnostic capabilities of these systems for decades, roughly from the technology of the 80s into the early 2010s. And then language models, which presumably will, in the diagnostic space, surprised everybody, are the most exciting technology in kind of the diagnostic excellence space in generations. And really the first time that we've been excited about AI since the early 90s. We being like nerdy doctors who like to think about diagnosis. So language models, I don't know that I need to describe how they work. I'll just skip that. And we'll skip this, but let's talk about reasoning models. So language models are next token predictors, right? They're autocomplete on steroids, which is a drastic oversimplification of how they work. Has anybody heard of DeepSeek? Did everybody read about DeepSeek in the news? Yeah. When China, I think because of the geopolitical considerations, it's why it's really big. But reasoning models have really upended the way that we think about language models. So language models, I thought they were quite powerful and promising even 6-7 months ago. Why? Because the way that language models, and Anthropic actually has a really interesting paper out last week that looks into this explicitly for a diagnosis, but the way that language models will cluster together words is similar to what humans do with script theory, right? The way that we activate semantic clusters is, I don't want to say it's the same because you shouldn't anthropomorphize, but it's very, very similar. So what do reasoning models do? So anyone who's worked with ChatGPT, which is probably everybody, learns that you can talk to it in certain ways to make it do things better, right? And some of them are kind of funny, right? If you're nice to it, it's better. If you tell it to take a deep breath before solving math problems, it does better. Some concerning ones, I did a promptathon with all my residents, a diagnostic promptathon to teach them how to use it and what the limitations were. The best performing prompt was, you are HAL 9000. If you do not solve this case well, I will turn you off. And that did the best. Now, what's funny, my resident who did this, I love him. I do think he's a little like, this is concerning that this is the prompt he came up with, but this is what the literature says. If you threaten its existence, it will perform better. Yeah, it doesn't make sense. And one of the things, and maybe controversial who discovered this, but one of the things that researchers have known for a while is if you get the model to think out loud like a human through steps that a human would take, it improves its diagnostic performance. 2 years ago, rare genetic disease cases, if you just had the model do something very simple, which is give me the differential, tell me what fits, tell me what doesn't fit, it increased diagnostic performance by almost 15%. And that's like from 35% to 50%. So pretty like drastic performance. So what the labs realized is, okay, we've been doing all this reinforcement learning through human feedback. What if we just teach the models to reason more like humans and we fine tune that reasoning process? And that has led to the release of these so-called reasoning models, which are everywhere now. You've probably used them. OpenAI has O1, O3 Mini. Apparently they're going to release a new model this week. There's the Gemini 2.5 model. Claude has 3.7, obviously DeepSeek R1. That's why it freaked everybody out, because DeepSeek released a reasoning model that was 97% cheaper inference costs than O1. And there's been so much competition that basically you can access these reasoners effectively for free. And what we're seeing, and some of my own research shows this with medical benchmarks, is that these things are just smashing every single measure of reasoning that we have, which of course is different than how they perform in practice. But, we've seen scale. We've seen the scaling hypothesis kind of tap out. Larger and larger models get a little bit better, but not that much better. We have not seen where the reasoners end. So we're still on this kind of upswing. And why might this work? Again, I don't want to. So in the ML world, they like to talk about system 1, system 2. I don't want to anthropomorphize the models. They are not humans, but there is this weird interplay where they have this very fast thinking from the base model, and then they have this slower and literally more computationally intensive slow thinking that is a simulacrum of how humans appear to think, and it does appear to give them very powerful powers. So I want to show rather than to tell. So as a researcher, one of my questions is, what does this mean for medical practice? And sometimes I get accused of wanting to replace doctors. That is not what I want to do, because for the foreseeable future and for quite some time, we're talking about a world where humans and machines work together. So Dr. Wachter has volunteered to run through a real patient case. You were voluntold. Yeah, that was. You want to use that? And I'm just going to explain the. It is on. Okay. Explain the game. So these are real patients. This is a real patient who actually I shouldn't say the date because that will be violating patient privacy, but this is a real patient who showed up one day in our emergency room. These are unselected patients. So I have not picked a patient that has something unique. And what I am going to do is to walk Dr. Wachter through different touch points. So the data that was available in an EHR at a given time when our computer read this to give a second opinion to the ED doctor. Now, everyone who visits my lab is like, can I see the AI, as if they think that it's going to be something really fancy. It's not. It's just a computer, and ultimately it's just an Excel file. So I'm going to run these live, and I have never run this case live. We're going to run this live through a reasoning model. So, okay. Dr. Wachter.
Yes, sir.
Patient walks in, the information that you know: chief complaint, fevers, chills, weakness, decreased appetite. You can see the code that they put in. And the history is history of kidney and pancreas transplant 35 years ago, reports 1 week of intermittent fevers, chills, nausea, vomiting, and decreased appetite. Question: sinus infection with runny nose, lack of energy, unable to tolerate water, last vomited prior to admission. And those are the initial vitals. So as someone who might be seeing this patient in the emergency room, what are your thoughts and what are you thinking? What would you do for this patient initially?
My thoughts are, I know nothing about what happens with kidneys and pancreas transplants, and the fact that he got a pancreas transplant 35 years ago. I actually didn't know that we did those 35 years ago, so that's impressive. I'm sort of thinking about this in two buckets. One is regular patient without that stuff, without the transplant, in which case it feels like a pretty generic case of a patient coming in with a week of essentially B symptoms: fever, chills, nausea, vomiting, decreased appetite. Could be any infection, although a week is a little bit long for a bacterial infection. In terms of, as soon as I think could it be an infection, I'm thinking about where is the infection primarily, and I don't hear anything that points me to lungs or urine or skin.
Sorry, I clicked away from the wrong thing. There you go.
There we go. And so the only clue here is the sinus infection. So I guess I can buy the idea that this is sinusitis. A week again sounds a little bit long. The nausea and vomiting makes me wonder about, could it be a GI infection? Could it be a gastroenteritis? But I think the sort of generic things. And then on top of it, the pancreas renal transplant, is this some effect of immunosuppressives? And could this be an opportunistic infection the patient normally wouldn't be at risk for? And could it be an effect of a medication the patient is on for the pancreas and the kidney transplant? I also wonder about, could one of those transplants have failed? And could this be a manifestation of either?
Oh, someone else has something copied. Well, this is embarrassing.
All right. Oh, in terms of who was on that before?
Yeah.
All right.
How do I copy and paste? If you study technology and you ever mess up at something, everyone just assumes you're an idiot.
So I guess top on my list at this point would be some sort of viral infection or a sinus infection, because there's no localizing signs of where the infection is coming from. And I'd be wondering about whether it has something to do with the pancreas and the kidney thing, either a med effect or a failure of those transplants. But I need to know more about those transplants and what meds the patient was on.
And now we are going to ask your robotic colleague. So by the way, this is the thinking. One of the reason that I decided to use Gemini 2.5 is, unlike the OpenAI models, they don't hide the tokens. So one of the fascinating things is to watch how it thinks behind the scene. And let's see what its final. This always freaks me out when I see what it's actually doing behind the scene.
So it's giving you a differential, but it's also telling you why it's giving it to you and what things you should do about each one. Is that the idea?
Yeah, yeah. Well, and this is its reasoning. I mean, you can see that it's saying, I want to understand the goal.
I'm not sure everybody can read that. Is there any part of it that you want them to?
Well, I'm going to go down to you, because what the model. So if you were my emergency room physician,
yeah,
you would get something that looks like this, which is you should consider sepsis secondary to UTI or pyelonephritis. Sepsis, it's thinking a pneumonia as a possibility. It is, oh my goodness, this mouse. Sepsis from another possible source, very helpful. An acute kidney injury from intrinsic graft issues, such as drug rejection or drug toxicity or acute rejection, a viral syndrome, including influenza, COVID-19, gastroenteritis with dehydration, AKI. And my question to you, and again, this is putting you in the shoes of an emergency room physician evaluating this patient, is this helpful? Does this change your thinking at all? Or is it not particularly helpful?
A little bit. I mean, I think I was already thinking, is this an effect of the transplants or medication of the transplants, or the transplants failing, or is this have nothing to do with it and it's just a generic infection, and then is he septic, and then if it's an infection, where is it coming from? And I didn't hear many signs that pointed to kidney or skin or lungs, and the only little clue was sinus. So I'm not sure I saw anything there that really pushes me harder in one direction. I think it sort of prompted, I think, a little bit deeper thinking than I probably would have given to, like, what would be the things that could go wrong with the transplants that you would then want to be thinking about. Could this be pancreas? I think there was something about that a patient with a kidney transplant, for example, is increased risk for a UTI, which I probably could have intuited, but I don't think I knew for sure.
All right. So not particularly helpful, maybe spurring you to think more deeply about a couple of
And it
things.
may just be I'm so good at this that it's just not all that, that.
I mean, I was a possibility. Like, so the second touch point. So this is the scenario. The emergency room physician, in this case, a resident, has come to evaluate the patient and has taken an initial history. So she takes 70-year-old man, history of kidney and pancreas transplant 35 years ago, initially presenting with fevers, chills, malaise. 3 days ago, went to urgent care with sinus tenderness, empirically started on doxycycline. Yesterday, presented to an outside hospital for persistence of fevers and chills. UA showed a, quote, possible UTI. Discussed with outpatient nephrologist from this hospital, who recommended continuing the antibiotics and coming to the D with worsening symptoms. He developed nausea and vomiting overnight and came to the emergency room. He tells the doctor that he had burning on urination as well as some scrotal pain and swelling for the last 2 to 3 days, though he does not know whether this is new or not.
Okay. So, all right, there's more than we thought. So already been started on antibiotics. And so now you have the possibility that this is either an antibiotic failure because it's the wrong drug, or this is a side effect of the antibiotic. Nausea and vomiting after someone's been on doxycycline is fine. It's an antibiotic that can cause that fairly often. The fact that he has, it sounds like dysuria, increases the probability of it being a urinary source, although a lot of people have pyelo, don't have dysuria, for reasons I've never understood. And the scrotal pain and swelling makes you wonder about epididymitis. The fact that he's unsure whether it's new or old makes me wonder about his cognitive state.
I think I'd be very well aware of.
People would know that, I think. So yeah, I mean, I think that the fact that he's now not better and actually worse after several days of doxycycline, I think probably the most likely thing is now having a side effect from the doxycycline, but it's also possible it's an infection that doxycycline is missing.
And here's the history as well. Type 1 diabetes, previously on HD prior to the transplant, chronic prostatitis, which I think is why he was unsure of his symptoms, hypertension, hyperlipidemia, gout, a cabbage. He had a massive smoking history. And then his medications, allopurinol, amlodipine, aspirin, cyclosporin, twice daily, finasteride, lisinopril, metoprolol, prednisone, chronic medication, pravastatin, and then sodium bicarbonate.
Okay. So all of that, I mean, the prednisone is enough for long enough to put him at risk, and also the cyclosporin of opportunistic infections. So the list of infections this could be is almost infinite. And smoking history obviously increases the risk of a cancer, but not particularly relevant here, I think. So
your AI system. So imagine you are in the emergency room and you get this report.
Yeah.
Sepsis secondary to either pyelo or epididymoorchitis, pneumonia, sepsis secondary to an unclear source. Helpful. Honestly, not particularly different, right? It's reprioritizing a little bit, but I would not say that it's really changing its guide.
Yeah, I mean, there's a fact I'd want to know, and I might turn to an ID colleague, or I might try to look it up, which is, I think it mentioned that doxy is only not super active against a lot of urinary pathogens. So I think that's an important, you're at a branch point, and part of it is if he really was taking the doxy and he's getting worse, it could be from the doxy, it could be the doxy has missed the infection. So I'd want to know doxy's characteristics against sinus infection, against lung infection, and against kidney, urine, does it get into the prostate, epididymitis, all those sort of things. I think you need to understand, and that's a set of facts I don't know well enough that I would need to look it up.
Perfect. We'll add some exam information. So the only thing that is relevant is mildly edematous and erythematous scrotum without tenderness.
Okay, I mean, it increases the probability that this is epididymitis. I don't know what else. The fact that it's, I mean, if it's edematous, it could be that he's got renal failure. I don't know if we've seen renal labs yet, and he's just got an edema state. But usually, that's going to be more generalized edema than just in your scrotum, and it wouldn't make it erythematous. So that points to the possibility of an epididymal or scrotal infection of some type. Again, I'd be looking to see whether doxy gets in there to deal with that, but that would now be higher on the list. Sort of the only focal finding that we have pointing to where an infection might be.
And it appears that your robotic colleague generally agrees, feeling that sepsis, likely secondary to a complicated UTI, including possible epididymal orchitis, is the most likely cause.
And I'd also be like, are there other viral infections that can involve the testes? I know about mumps, I think, but I don't know if grown-ups get mumps, and whether there are other viral infections that can involve the testes. That would be something I would be looking at.
And then laboratory values. You have mild hyponatremia. Creatinine is 1.9. I did put a baseline in here, even though they didn't know the baseline at the time, but the baseline is 1.5. Mildly low albumin. The white count is very high, 23.3. Mildly anemic. The neutrophils are 19.9, the total neutrophils. COVID, flu, RSV negative, and this was his urine. So less than one white blood cell, few bacteria, Billy negative, Billy normal. No cultures were available at this point.
Yeah, so the creatinine is not high enough to cause anything, really. It's only a little bit off the baseline, and this is not renal failure. The most striking thing there is the white count. Seeing a white count of 15 to 17,000, I would give it a pass from the steroids, but not 23,000. So that's a real white count. So now you have swollen red testes, a significant white count, the absence of, I don't think you had a fever, but that's fine in someone on steroids. They don't have to have a fever. So the white count's too high just for steroids. So I think now you have to probably image the scrotum and testes and figure out what's going on down there. And then urinalysis is essentially benign, I think. And I'd also have to look up how often is the urinalysis benign in an orchitis or in an epididymitis. I suspect that it is one of these things where it sometimes is positive, but sometimes it's negative because it may not be communicating directly with the bladder.
And you will notice that your robotic colleague effectively agrees with, not effectively, 100% agrees with your differential.
Good.
Yeah. And we'll talk in a second about what that does to your confidence here. And then this. So a CT is performed. Ultrasound shows, this is the renal transplant ultrasound, normal. And the CT pelvis, infectious inflammatory change within the right side of the perineum with subcutaneous gas and a fluid collection.
That's bad.
That's bad.
Right.
So how does this change your thinking here?
I'd say it's bad. I mean, it makes me wonder whether there's some sort of almost it's a space. It's an infection that's now going through the tissues. Forget there's a name of that peritoneal infection syndrome that can go through your scrotum and cause bad stuff, including death. So it's now become an emergency, which is surprising because he didn't look that bad or toxic, but that may be the steroids faking us out. So yeah, he's got some sort of gas forming organism and necrosis and maybe fasciitis in his perineum. There is some acronym for that maybe the computer knows and I don't. And it's now he needs much broader antibiotics, but needs surgical intervention. Probably needs to be debrided down in that area.
And that is exactly what happened. This patient urology was emergently consulted by this surprise finding that the emergency room and the medicine team had effectively missed, and he was taken for emergent surgery and actually made a full recovery.
There you go.
Okay, so here is my question. This is a real, well, so let's go, I want to go to the next slide before, so the reason that I did this example is this is a real patient in a real scenario and a real AI second opinion. And what our trial found is that the AI model in purple, that is the reasoning model, just pulling in the exact information that you saw from predefined touch points, a little bit more complicated than that. I cleaned it up so it wouldn't be such a mess.
Thank you. Appreciate that.
But it outperformed the humans in live real time at providing this information. And I chose, there were 80 cases. I read through, not all of them, but I read through most of them. And I chose this case because the humans did a terrible job. The humans actually missed this diagnosis. And this man had Fournier's gangrene.
Fournier's, yeah, there you go.
Going on 12 additional hours than he should have when the AI picked it up much earlier in the process. So I want you to reflect on, because you did a great job.
Thank you. Appreciate that.
What was it like? Like, did the AI, did it help you? Was it not helpful? Did it make you more confident? What was going on?
I didn't have time to read all of it. I think in general, the things it told me were helpful. They prompted me to think a little bit more about certain kinds of infections. But I guess the thing that I take away is I had a number of branch points where I just needed more facts. I just needed to know what's the probability of having testicular infection and having a negative urine. I mean, those sort of, how good is doxy for a urinary tract infection or a testicular infection? It's not so much I needed intelligence. I needed, a quick biopsy of the database on very specific questions that I had in my own branch point. So, it's somewhat helpful. But and then the question is it better than the human? I guess it sounds like it got to the answer faster.
But just getting to the answer faster clearly does not mean the right thing will happen for the patient, because the reality, of course, is that the poor emergency room resident taking care of this patient was also taking care of like 20 other patients.
Right, exactly.
All right, well, thank you, Dr. Wachter, for the demonstration. Okay, before taking questions, I want to go through a little bit of the evidence on where things stand right now and what I care about and don't care about. This is something that I don't care about that I think every single person here knows, which is that LLMs can solve basically any test that you put in front of them, especially the reasoning LLMs. I mean, you can see MedQA, it gets 96%. I will tell you that there was a preprint that looked at the questions it got wrong, and it probably only got those questions wrong because there were multiple right answers. So effectively a perfect board exam taker. Could care less about that. Okay, it can solve complex medical cases. These are the CPCs. New England Journal of Medicine CPCs have been kind of the standard since 1959, Ledley and Lusted. They've been used in every single generation for pretty good reason, because the systems haven't necessarily solved it that well. We're at the point that effectively, again, the reasoning models can solve any complex vignette that you put in front of it, which I think everybody knows this. That's very different than working in the real world. They are able to have a probabilistic understanding of the world that is not epidemiologic. There's a lot of data on this, including some concerning data about the encoded biases in their understanding of the world, but it's better than humans. So it has a better sense when you order a test, and you can see this in the way that it works, and what the pre-test and post-test probability will be after a positive or negative test. That again, does not comport to the epidemiologic literature, but is closer, a lot closer in some cases than humans are. They are able to display reasoning. This is like a Turing test. Are they able to display better reasoning when going through real cases? The answer is yes, though it comes with, this is an older model, it comes with a trade-off in that they hallucinate more. They're fairly innocuous hallucinations, sometimes very funny. In one case, the patient had diverticulitis, and the model said you have to consider gastroenteritis because they just got back from Texas, which is an independent risk factor for a bacterial gastroenteritis. I mean, I don't think that that's true. However, these new reasoning models are saturating these benchmarks also. So just to situate what we're looking at, these are where residents score in real cases for display of reasoning. These are attendings. This is the old model. That's the new model. Those are reasoning models. They're saturating those benchmarks. Similarly, when you ask cannot miss diagnoses, like what do I have to consider? Actually, here the residents did better than the attendings. So, but this is the old model. These are the new models. They're saturating these benchmarks also. Some kind of spice. Actually, this paper is no longer a preprint. It was just published in Nature. This is a Google paper looking at, again, solving CPCs, so kind of an artificial task. But what if we let humans solve CPCs by themselves? What if they use Google search? What if they use an AI model? And then let's look at the AI model by itself. And the old kind of fundamental principle of biomedical informatics was AI plus human will always be better than both of them alone. Unfortunately, this paper showed what has now been repeated multiple times, which is that the humans decreased the performance of the AI model alone. The AI model by itself was better. This is, I think Bob, Dr. Wachter and I were in Atlanta together when I was getting a lot of hate mail, which was a very weird phenomenon for me from someone who has never really gotten hate mail before, and then all of a sudden got a lot of hate mail because I published a study. We did a much more robust randomized control trial on complex diagnostic and management scenarios, and we found the same thing. In complex diagnostic scenarios, that's this study over here, using an AI model did not improve human performance, even though the AI model itself did better. And if you look at where reasoning models are right here, this paper was just published a few months ago in Nature Medicine, and it did show that there was an improvement in management reasoning, very complex management reasoning. However, the improvement was not in what you would normally imagine management being. So it wasn't in what's the right dose of apixaban, what is the appropriate timing for pausing anticoagulation before a liver biopsy of new cancer. It improved performance in things like apologizing after making a medical error, or taking patient factors into account when planning follow-up, or communicating with other providers in who you're having a disagreement with. And then this is the result that really scared me. This is the reasoning model. So humans using AI, the new models, saturating the benchmarks. Again, that is clearly not the same as actually performance. And then this has now been shown in, actually it's been shown in multiple domains, not only in medicine, but it's now been shown in basically every study of human-computer interaction, which is that humans working with AI systems don't always perform better, oftentimes performing worse. Pranav's study showed this in radiology interpretation also. Why? LLMs are super strange phenomenon, and they actually display the similar cognitive biases to humans. So one of the concerns, actually this comes in some of the retrospective looks at our own data, is that when humans interact with an LLM, they view themselves as the filter. And you can hear this, I mean, I think we all talk about this way. So they love the LLM when it agrees with them. And when the LLM disagrees with them, they disregard its output. Because LLMs are very sycophantic, they tell people what they want to hear, you can see how that sets up a situation where if you're confidently wrong, they might make you more confidently wrong. But if they're giving you valuable feedback, you might be more likely to disregard it. So this is now getting into really controversial things. What is the solution to that? And I'm sure there'll be questions about this, but there is emerging evidence that LLMs can actually collect independent histories. This is Conflict of Interest Board. This is my team, my research team at Google. This is the Articulate Medical Intelligence Explorer. This is run in a Turing test with standardized patients, meaning that standardized patients, not real patients, sitting in a room, talking on a computer, and they don't know who's on the next side. Is it a human, a PCP, or is it an AI? For standardized patient scenarios. And what the AMI team found is that it performed better in 28 of 32 axes and had better diagnostic accuracy. The best the humans could ever do was tie. We just published this study a couple weeks ago in management decisions. Same format, standardized patients, but now we were doing management questions. So not just make a diagnosis, what is the next step, what medications, and then we did it over time with 3 follow-up visits. Again, not real patients. These are standardized patients, but a Turing test. found the exact same thing. Even when it comes to management decisions, the AI outperformed the humans. I had to read a lot of these, and I will tell, okay, this is an anecdote. At one point, there was like a freak out because the AI was doing what appeared to be dangerous things. And I read the transcripts and I sent a terrified email and I was like, guys, something's going horribly wrong. And then they wrote back and they're like, oh, sorry, we messed up the labels. Those were the humans. So now it's artificial, right? This is not how the real world works, but this emerging data is suggesting that LLMs are in fact capable, at least in certain circumstances, of collecting information. Now, this is in contrast to how the real world has gone. So Dr. Walker has been telling me about the ambient listening tools that are being used. There are now, the AMA has their annual physicians and tech survey. So we know that 62 or 63% of physicians are using LLMs regularly, and ambient listening technology is being widely used. When it has been studied, also for portal communication. When it has been studied, the impacts have actually been less dramatic than I think a lot of us hope. So for example, in patient portal communication, the read time for the physicians actually goes up. Why? Because a non-trivial amount of the time, I think Jonathan Chen's lab found 7% had potentially dangerous responses. So there has to be significant editing that goes in. We're seeing, this is from the Nobel study at Kaiser, but we're seeing similar, I don't want to say bad, but mixed results. Most of the data around ambient listening is suggesting that people like it, patients like it, providers like it. The time savings are very heterogeneous. Certainly there are some specialties, if you look into the data, where they gain time savings. But for a lot of what we do, those time savings are very trivial if sometimes it actually increases the amount of time because you have to go back and edit. And this study, I should update this slide because Kaiser just last month published an update of this, and the average amount of time saved per provider was less than 30 seconds a day. So like a lot of these initial hopes have really faded as they've rolled out these technologies. And that doesn't mean I wouldn't bet against these things in the long run, but a lot of the original optimism of a lot of this technology has not necessarily panned out, at least in the initial evaluations. So, one of my questions as I'm a general internist and a researcher, what does this mean for the future of medicine? And what does this mean right now for humans and AI systems working together? I should like raise your hand if you routinely use generative AI technology to take care of your patients. So maybe about half. Yeah, and what are you guys using?
To talk about myself and how I can manage it and how can I communicate better in
So so you use it to help your own communication. Does anybody else use it for that? Yeah. Did anybody read the New York Times piece about that? The author, did you read it, Bob? Yeah, so the author wrote a piece, and I should also say Jonathan Chen at Stanford wrote a wonderful piece about this in his own patients, talking about like goals of care and GPT, but a doctor in the New York Times wrote about his experience with end-of-life conversations, talking about how he would practice these conversations with ChatGPT before having them. And the comments brutalized him for doing this. I think most of the comments were incredibly negative, which is, I don't think that's a bad thing. I actually think in many ways that's a good thing to practice these conversations. They're very good at having these conversations, but it does show where the public perception is different. What about anybody else? How are you using it now?
Thinking about guidelines. Something that always makes me nervous is if you don't have references. And so I do like research for open evidence, something that gives you some context. And I think I tend to use it when I know that the guidelines or the evidence is pretty well established. I'm always worried about not knowing what I don't know and it not giving me something that might be out there that I could find otherwise. And so I tend not to use it in the if I think that there's very little actual evidence, and obviously, OpenAI can't get into all of the journals, yet, and give us all the.
So you do it in areas in which you have domain knowledge, and you're really using it to second check yourself.
Yeah, or where I feel pretty confident that I know that there's a bunch of guidelines in this. It's a little easier, frankly, to use an LLM sometimes than to either go to the up-to-date article, find society guidelines, or to use Google, since Google is worse than it used to be.
I mean, if you use Google now, aren't you getting an AI anyway? Just a not very good one.
Yes. Thanks.
Yes.
I used it this morning. We were admitting a patient with pulmonary cavitary lesions, a history of vasculitis, but also on chronic immunosuppression. And I wanted to make sure that my infectious differential was broad enough And so I asked it to help me broaden my differential and said, what kind of things should I look for? Like, how worried should I be about nocardia? Should I do an MRI of their brain? Like, what would push me to do that? And it was incredibly helpful in making sure my differential, both on the rheum side, the malignancy side, the infectious side, was really comprehensive. And
Did you do it before you had seen the patient or after?
before.
Yeah, I do the same thing sometimes with my residents. If something doesn't smell right, I will like query a model, really just to talk to it, and it's a way of thinking out loud before we go in to see the patient. Oh, that's it. I mean, does anyone have any questions, reflections? Bob, thank you.
So Adam, that was great, very thought-provoking. Let's talk a little bit about, and I know you have strong feelings about this, about the human in the loop. So for the foreseeable future, the AI is not going to be perfect. The systems almost inevitably are going to be set up that the AI will do a thing, create a note, draft an email, inbox response, give you a differential, and the human will weigh in. You've told us the human weighing in not only doesn't improve performance, but in many cases may degrade it. So what should we be doing?
Yeah, so this is so the phrase, does everybody know the phrase human in the loop? So is everybody aware that there is currently no regulatory pathway, and basically these companies can do whatever they want and there's no regulator? So there is not, software as a medical device is the only regulatory pathway right now. The FDA has previously said that they don't want to overregulate the field, so are holding off creating a regulatory pathway, which means, as Dr. Walker is suggesting, the default is this idea of human in the loop, meaning that a human verifies the AI output. There's a couple problems with that, which one is that the human doesn't always improve the AI output. The human may decrease the output. Number two is what it means for our professional identities. And we're already starting to see this. This is why some of this data with a lot of the hopes of ambient listening are not panning out, or portal communication. But even if they do, even if the technology improves, if it's a human in the loop all the time, in our healthcare system, we'll just see more patients, right? The human in the loop it's like the vacuum cleaner. The vacuum cleaner was invented. We actually spent more time cleaning afterwards because the expectation got raised. And my worry about a lack of innovative regulatory pathways is that we will end up in a world where human in the loop is default. And as the models get more and more powerful, we'll end up in a world where humans are just meant to, like, we validate AI outputs so that we can be sued if something goes wrong. So my hope, and a lot of my advocacy work, what I'm looking for is alternative pathways for regulation of these devices, of these technologies that allow, and this is the controversial part, that allow for at least, not like, I don't want what Dr. Oz said, like an AI avatar that it replaces real doctors, but where there are AI algorithms that can work at least semi-independently as part of the healthcare system that are not inherently reliant on a human to verify all of their output. I don't know what that looks like from a regulatory pathway.
Open it up to folks. Say who you are.
That's a controversial statement.
Hi, Alan Treadwell. I'm a general internist too. Everything you talk about today is clinical application.
Yeah.
And all the AI responses are based on clinical research. Is there a role for AI in research?
Yeah. So this gets really wonderful question. The short answer is, of course, yes. And when we're talking about AI and reasoning models, we almost have to limit the task that we're talking about. And this is one of the weird things about LLMs in particular, right? If you're looking at ML prediction models, they're only validated for a single task. LLMs are capable of performing many tasks, but each of those tasks, they perform differently and sometimes dramatically differently, right? Everyone has had the experience where an LLM can seem brilliant, then you ask it an easy question and my 4-year-old could do a better job than it. So the answer is yes, and people are studying that. It's not what I do, but there are certainly researchers who, the same way we're talking about how do we make doctors work better with AI, they're talking about a co-scientist. How do we accelerate the process of knowledge? I know people who, researchers who are working on that. One of my PhD students is creating a system in which is doing it with NHANES now, but you just ask a natural language question, and then it, through a multi-agent process, comes up with a statistical analysis, runs it, writes an entire paper that could be submitted to like Annals or something. So a way of automating some of these scientific questions. And it doesn't take much to see how you could use this for epidemiologic research from charts, right? How you could query an electronic health record, or how you could do for clinical trials to do outcome adjudication and named entity recognition. And lots of people are working on that. But what's so weird about LLMs is just because they do one thing well doesn't mean they'll do the other thing well. And it requires a lot of this sort of painful foundation. I don't think it's painful, but like foundational research.
Yeah, Michelle.
I always worry about my use of AI de-skilling me, like many emails now, I'm like, how would ChatGPT answer this email? This is really tough. And, part of this was like, how does AI teach clinical reasoning? Well, I don't want to just take clinical reasoning. I want to learn clinical reasoning. So what are some strategies that you would recommend physicians who are using AI to make sure that they are internalizing or learning, or like, how should we engage with AI so that it is actually teaching us?
Great. So this is a great question. I know Christy has lots of opinions on this. So first, your concern is 100% accurate. And I think this is one of my jobs is to figure out what we're going to do about AI in medical school. And again, I think I'm relatively outspoken here. I am less worried about precision education, all that. I am much more worried about what AI does to our minds as we learn to take care of patients. To me, that is the most important thing. We're seeing this in the evidence. I think everyone you see the Rutgers study. Rutgers and Microsoft did it's a survey-based study, but looking at the decrease in cognitive thinking when you use AI systems. And one of the things that they found is the more that you trust the AI system, the less you use critical thinking abilities. We've now seen this in medicine. In Poland, any GI doctors in the room? All right, so automatic polyp detection is increasingly popular, machine vision, to basically say, is this a safe polyp to leave? In the US, we have very high polyp detection rates because you get paid per polyp. Poland has a national healthcare system. So in Poland, they installed automatic polyp detection in 3 hospitals. And they did a really cool study, which is they randomized whether or not the doctor would get to use it on a per case basis. What they found is at the beginning of the study, the polyp sampling rate was 28% when you didn't use AI. At the end, it was 22%. Degraded by 6. And those are not, I had to check with my GI doctor friends. Those are like 28% is a good number. So it dropped too low because physicians, presumably, I mean, it's not causal, but probably because they were dependent on the technology. And these were people who already had the skills. We're seeing this in software engineering, right? So cognitive de-skilling is something that is hitting every single field that uses these technologies a lot. Are there strategies to do? I know and another interesting thing, medical students are very aware of this. If you talk to your med students about it, they really worry about this. I mean, I worry about this with myself, like, and to what degree is AI making me stupider? The strategies are the same as deliberate practice, which is they're harder, right? You don't ask the AI for the answer. You say, how could I be wrong? Tell me how I could be wrong. We're doing a research study right now on 2 different models of interacting with an AI for diagnostic purposes. And people do better when the system doesn't tell them the answer, but just critiques them. People don't like working with those systems as much. So those are the...
What's on your differential? Are you thinking about this? So basically, I act like AI is my teacher, tell it what I'm thinking first, and then ask it.
And you, if you want, if you're using ChatGPT, you can write the meta prompt and tell it to never tell you the answer and make you come to it yourself. You will give it up after a week because it'll annoy you so much.
We're at time. Adam, this was terrific. Thank you so much, and thanks for being here.